Studies show that delirium occurs in 20 to 80% of ICU patients, with higher rates in mechanically ventilated patients. This wide range is due to differences in patient populations, ICU types, and assessment methods. ICU patients are particularly at risk due to severe illnesses, invasive procedures, sedative medications, and the ICU environment itself, which can be disorienting. Despite its prevalence, delirium is often underdiagnosed due to its fluctuating nature and the presence of hypoactive forms, which are less obvious than hyperactive delirium. Therefore, it is important to use a validated tool for delirium screening on all ICU patients. Here is how a patient described his state of mind when he was in the ICU. The time I spent seems like it was in a huge, empty gray space, sort of like a monstrous underground parking garage with no cars, only me, floating or seeming to float on something. Every once in a while, I would get to an edge of something horrible, and I thought, if I just let go, then this horror will be over. Your role is to prevent the occurrence of delirium and detect it as early as possible using the Confusion Assessment Method for the Intensive Care Unit, or CAM-ICU. CAM-ICU is a validated diagnostic tool specifically designed to assess delirium in critically ill patients who are in the intensive care unit. This tool is designed to be quick, non-invasive, and easy to use, making it suitable for the ICU environment where patients may be unable to communicate effectively due to intubation or sedation. Delirium is an acute alteration in mental status characterized by confusion, inattention, disorganized thinking, and sometimes altered levels of consciousness. The key features of CAM-ICU are 1. Assessment of acute change or fluctuating course. This element evaluates if there is a rapid change in the patient's mental status from their baseline, which tends to fluctuate during the day. 2. Inattention. The patient's ability to maintain attention is tested, often by asking them to perform simple tasks, like squeezing the examiner's hand upon hearing a specific letter in a string of letters being read out. 3. Disorganized thinking. This is assessed by asking the patient a series of questions or giving them simple commands to test their ability to think in a coherent and logical manner. 4. Altered level of consciousness. This involves determining if the patient's level of consciousness is anything other than alert. Let's go in the details of the CAM-ICU in 4 simple steps. The first step is assessing for fluctuation or acute change of mental status. You would do this by asking the question, is the patient different than his or her baseline mental status? Or, has the patient had any fluctuation in mental status in the past 24 hours, as evidenced by fluctuation on a sedation level of consciousness scale, such as RASS, or a change from previous delirium assessment? If the answer is yes to either of the previous questions, then proceed to the next step. If the answer is no to both questions, then the patient does not have delirium, and you can stop here. The second step is to test for inattention. You would do that by performing the letters attention test. Tell the patient, I am going to read you a series of 10 letters. Whenever you hear the letter A, indicate by squeezing my hand. Then read letters in Savehar in a normal tone 3 seconds apart. Errors are counted when patient fails to squeeze on the letter A, and when the patient squeezes on any letter other than the letter A. If the patient squeezes on all letters, consider all incorrect, same if the patient does not squeeze on any letters. If the patient had 2 errors or more, then proceed to step 3, otherwise, your patient is not delirious. In step 3, you assess for disorganized thinking by asking simple questions with a yes and no answers, such as, will a stone float on water? Are there fish in the sea? Does 1 pound weigh more than 2 pounds? Can you use a hammer to pound a nail? Errors are counted when the patient incorrectly answers a question. You can also demonstrate disorganized thinking by saying to the patient, hold up this many fingers, and you hold 2 fingers in front of patient. Then ask him to do the same thing with the other hand, but do not repeat number of fingers. If the patient is unable to move both arms, then ask him to add 1 more finger. An error is counted if patient is unable to complete the entire command. If there is at least 1 error, then your patient is delirious. Otherwise, proceed to step 4. The last step involves assessing for altered level of consciousness. You would do that by performing a RASS assessment, and it would be positive if the actual RASS score is anything other than alert and calm, or 0 score. If this step is positive, then your patient is delirious, otherwise, your patient does not have delirium. In summary, to diagnose delirium using CAM-ICU, the patient must exhibit both the first and the second features, acute change in mental status, and inattention, along with either disorganized thinking or an altered level of consciousness. Regular assessments with CAM-ICU can help in the early detection and management of delirium, which is crucial given its association with longer hospital stays, increased mortality rates, and higher risks of long-term cognitive impairment. It is recommended that all patients in the ICU be screened for delirium with CAM-ICU at least twice a day. Thank you.